Next in this course, we will review routine newborn screenings. Please review the legal disclaimer. Students will be able to verbalize in this course what routine newborn screenings are, what are the goals of these screenings, how to prepare the supplies and equipment for these exams, patient educational topics, timing of the screenings, the benefits, and lastly, students will be able to verbalize the procedural steps with each routine newborn screening. Routine newborn screenings are part of the scope and responsibility as midwives to care for the newborn's first few weeks of life. It is our responsibility to educate families about routine care, standards during pregnancy, birth, and postpartum care, and if a family declines a routine screening, consents and strong documentation is present. Most of these illnesses are very rare, but can be treated if caught early. One of the newborn screenings we will discuss is the newborn metabolic or the PKU screening, sometimes called or referred to as the Hill Stick or 24-hour test. This test determines if a baby may have one of many of the serious metabolic conditions. Using a few drops of blood from the baby's hill, and is typically done around 24 to 48 hours after birth. Another newborn screening we will discuss in detail is the critical congenital heart disease or CCHD screening. CCHD screening is a pulse oximetry screening. It uses a sensor to determine if a newborn may have a certain heart condition, typically done around 24 to 48 hours after birth. Another routine screening is the newborn hearing screen. Midwives can be trained to offer this service, or they may refer to a local audiologist. This screening determines if a newborn might be deaf or hard of hearing. Goals of the newborn screenings are to provide education for providers and families, early identification, which will help with early intervention through timely follow-up, and to reduce the morbidity and mortality. The metabolic PKU screening, with PKU standing for phenylketonuria, is a rare disorder that prevents the body from properly breaking down a substance called phenylalanine, or PHE. PKU is part of proteins that are found in many foods and in artificial sweeteners called aspartame. This happens after birth, usually when the baby is between 24 and 72 hours. To prepare for this test, you start by cleaning the baby's heel with alcohol and poking the heel with a small lancet. You would then collect a few drops of blood and apply a bandage to the site. The test should be done no sooner than 24 hours after birth to prevent possible PKU complications. This will help ensure that the results are also accurate. The test should be done between 24 and 72 hours. Again, no sooner than 24 hours to ensure the baby has taken in some protein, either from breast milk or formula. Studies have shown that babies whose mothers hold them skin to skin or breastfeed them during the procedure shows less distress. Wrapping the baby tightly in a blanket or offering a pacifier dipped in sugary water may also help ease the pain and calm the baby. After the initial PKU screening is completed, a follow-up testing confirms that the child has a disease and treatment can be started before symptoms appear. Blood screening tests are used to detect a number of disorders and may include the following: amino acid metabolism disorders, congenital adrenal hyperplasia, cystic fibrosis, fatty acid metabolism disorders, human immunodeficiency disease or HIV, sickle cell disease, and other hemoglobin disorders and traits. It may also screen for toxoplasmosis. Other indications for this screening are listed. Important to reiterate, if a baby is tested before 24 hours, they may need to be retested. Some babies who have had treatments such as transfusions or dialysis may be tested later or may need further testing after their blood has returned to normal. Between 24 and 48 hours after birth, the practitioner will inform the mother that it's time for the newborn's blood spot screening. Babies can stay swaddled or nursing during sample collection. Heel sticks should be done on the most medial or lateral part of the heel to avoid injury. You would then make a quick pinprick of the baby's heel. The midwife will then collect a few small drops of blood from the baby's heel. Then those few drops will then be placed onto small circles on a collection card. Once the blood spots have dried, the card is sent off to the lab to look for signs of certain serious conditions. Let's discuss in detail the critical congestive heart disease screening. CCHD screens for a group of heart defects that can be life-threatening and require medical attention within the first few days or first year of life. About 200 out of every 100,000 babies have CCHD. Children with CCHD are born with a wide range of problems with the heart structure and may require early treatment. These problems prevent the heart from pumping blood efficiently to the lungs and to the rest of the body. You will prepare for CCHD screening by ensuring that you have a pulse oximetry and that the baby is as warm as possible. After or during nursing is a great time to do this screening, as this is often the time when the newborn will be most calm. Newborns with CCHD typically appear normal at birth. Screening identifies CCHD before symptoms are detected. Early identification can result in better outcomes. The CCHD is typically done after birth, or usually when the baby is at least 24 hours old. Earlier identification of hypoxia will assist you in monitoring and treatment, which may lower the risk of additional complications and may prevent death. Let's review the procedural steps. The midwife will complete this screening at a routine postpartum visit, usually between 24 and 48 hours after birth. You will place a small wrap on the baby's skin, usually around the right hand or wrist, and on either foot. One side of the wrap has a light and the other has a sensor. You will connect the wrap to a monitor that uses the sensor's reading to calculate how much oxygen is in baby's blood. The pulse ox machine calculates the baby's oxygen level when the sensor is accurately placed. Place the photodetector portion, the probe, on the fleshy portion, again on the right hand. Place the light emitter portion, or the probe, on either foot. Additional sensitivity is gained by testing the right hand and one foot. Using the left hand is not recommended because of proximity to the ductus arteriosus. If having trouble, make sure baby is holding very still and warm. This is another screening that's great to complete when the baby is breastfeeding or immediately after breastfeeding. Some states require you submit the results to them. In order to pass the screening, the pulse oximetry readings must be greater than or equal to 95%, and there must be a hand-foot difference no less than 3%. For example, if the SpO2 is 99% in the right hand and 95% in the left hand, this is a difference of 4% and considered a failed screening. This test should be repeated 3 times to confirm, allowing 1 hour in between each test. Also, if there is a failed screening, a referral should be placed to the pediatrician. The pulse oximeter values for the right hand are located in the column on the left side of the grid. The rest of the grid contains the pulse oximetry values for either foot. You want to again obtain values for both the right hand and either foot. If the value falls in the green section, no action is needed. If the value falls in the yellow or red section, additional action is required. Refer to the AAP-endorsed CCHD screening algorithm to determine the action required. Detectable CCHD defects through screening may reveal several conditions, such as hypoplastic left heart syndrome, pulmonary atresia, tetralogy of Fallot, tricuspid atresia, and other potential serious heart complications. Secondary targets includes those listed. This screening may reveal a single ventricle, coarctation, an interrupted aortic arch, and others. Some factors that may affect the pulse oximetry interpretation: the translucency and blood flow where the measurement is taken, extremely low body temperatures, a blood volume deficiency, and an exposure to strong light while taking measurements. If results are under 90%, consider sending the baby to urgent care if unable to be seen by the pediatrician that same day. If the baby does not pass the pulse oximetry screening, the pediatrician may recommend additional testings to determine if the baby's heart and lungs are working well. Those additional screenings may include an echocardiogram, EKG, and or chest x-ray. Lastly, we will go into detail explaining the newborn hearing screen, also called the automated Otoacoustic emission test. The newborn hearing screen will identify babies who have permanent hearing loss as early as possible. This means parents can get the support and advice they need sooner. 1 to 2 babies in every 1,000 are born with permanent hearing loss in one or both ears. This increases to about 1 in every 100 babies who have spent more than 48 hours in intensive care. Most of these babies are born into families with no history of permanent hearing loss. A failed hearing screen could be due to the baby being unsettled when the test is done. There may have been some background noise, or the baby may have had fluid buildup or temporary blockage in the ear. For that reason, the baby will be offered a second test. This may be the same as the first test, or another type of assessment may be done, called the Automated Auditory Brainstem Response, or AABR test. The AABR test involves placing 3 small sensors on the baby's head and neck. Soft headphones are placed over the ears and a gentle clicking sounds are played. This test typically lasts between 5 and 15 minutes. Without newborn hearing screening, it is hard to know when there are hearing changes in the first months and years of baby's life. Babies may respond to noise by startling or turning their heads toward the sound, but this doesn't necessarily mean they can hear all the sounds around them and everything that is being said. Babies who are deaf or hard of hearing may hear some sounds, but still not hear enough to understand spoken language. Infants who are deaf or hard of hearing needs the right support and early intervention services to promote healthy development. If the hearing status is not identified, it may have negative effects on the baby's communication and language skills. Long-term, a missed hearing loss can also impact the child's academic achievement and social-emotional development. Infants who are deaf or hard of hearing require adequate support, care, and early intervention services to promote healthy development. If the hearing status is not identified, it may have negative effects on the baby's communication and language skills. Longer term, a missed hearing loss can also impact the child's academic achievement and social-emotional development. Newborn hearing screenings again are typically done during the routine postpartum care within the first few weeks of life. This test can be performed by a midwife if they have the proper equipment. If not, the patient should be referred to an audiologist. If the patient gives birth in a hospital, a newborn hearing test is usually offered before they are discharged. Step-by-step guide includes timing. Usually after 12 hours of life, the baby is assessed in a quiet room during a calm period for the baby. You may ask the patient to hold the baby during screening, or the baby may be swaddled. There are 2 types of hearing screenings that the baby may have. The Otoacoustic emissions, or OAE, utilizes a small earbud that is placed in each of the baby's ears. These earbuds will play soft sounds for the baby. The earbuds are then connected to a computer that measures how the ear responds to those soft sounds. If the baby's ears are working as they should, the computer will detect a response. If the baby is deaf or hard of hearing, the computer will not detect a response. If the automated auditory brainstem response is used, again the AABR screening, during this exam, you will place earphones over the baby's ears and small sensors that looks like Band-Aids on the head and neck. The earphones again play soft sounds for the baby, and the sensors measure how the baby's ears and brain responds to those sounds. This info is then sent to the computer. If the baby can hear, typically the computer reports a response to those sounds. If the baby is deaf or hard of hearing, the computer records either a very small response or no response at all. The baby may not pass screening if the baby is deaf or hard of hearing in one or both ears. If there is fluid in the ear, he or she may also fail the screening if there is too much noise during the screen, such as excessive movement or crying. The benefit of this screen is that results from the hearing screen are ready as soon as the test is done. If the baby does not pass and resulting in a fail, the baby will then be referred to a specialist for more evaluation and testing of its hearing. This second check usually happens 1 to 2 weeks after the first. In conclusion, routine newborn screenings are part of the scope of midwifery. It is our responsibility to educate families on their options with screenings available for newborns' first month of life. If a family declines a routine screening, consent and strong documentation is present explaining your informed consent and reasoning parent declines to test. The newborn metabolic or PKU screening determines if a baby might have one of many serious conditions. The CCHD screen uses the sensor to determine if a baby may have a certain heart condition. Newborn hearing screen determines if a newborn might be deaf or hard of hearing. And lastly, the goal of newborn screening is to educate providers and families for the early identification and early intervention through timely follow-up, which will reduce morbidity and mortality.